So welcome to our next podcast in our clinical strategy series. My name is Charlotte Routh. I'm one of the Trust clinical strategy leads. So first of all, in this podcast, I just want to introduce you to the naming of our clinical strategy. So we've now named our clinical strategy Lifelong Care, which is just a nod to the fact that we look after people throughout their lives, right from birth to the very end of their lives. And we work alongside our patients and people outside of our organisation to ensure we're there when they need them, but also to be proactive in disease prevention. So we're changing our focus to a naming of lifelong care. But today we're here to talk about the new front door model at the Northumbria Hospital, and I've got Jo Hughes, who's one of our emergency department consultants here, and Julian Coffey, who's our new clinical lead for the front door model and urgent treatment centre as well for a while. So Jo, can you tell us a little bit why we needed to make a change at the front door of the hospital?
Yes, so NSEC has a single front door that all patients will walk through, and we felt that every patient that walked through was getting the same outcome, and there wasn't really any consistency about whether you ended up in the place that you needed to be. Okay. So if you walked through the front door, you ended up in the emergency department, and then at some point further down in your journey, you might end up somewhere else. And what we thought was, if we could get people to the right place as early on in their journey, so that they were seeing the right people and getting the right investigations, the right care, that would be better for them.
So we know there's been lots of stuff in the national news about how busy emergency departments are, and we've seen that in Northumbria, haven't we? Year on year, the emergency department get busier, but not necessarily, as you say, having the right patients there. So what are the changes that we've made?
So we've started a few years ago by putting a senior clinician at the front desk, but it started at the front desk of the emergency department, so that it was still, if you walked into NSEC, you ended up in the emergency department, and we felt that that was the wrong thing, that the emergency department should be a destination if you needed to be there, okay, so that we could offer patients that came to our emergency department a really good service, okay, and that if you didn't need to be in the emergency department, we could get you as early on as possible to the right place. So we moved the initial meet and greet by a clinician to the very front door of the hospital in front of the emergency department, to try and make sure that as soon as you walk in, you're sent to the right place.
Okay. So you've said that you've been doing that for a few years. So why did we need to make further changes? Julian, can you tell us a little bit about that?
I think what we found, we started off moving the meet and greet and the initial clinical contact to the front door and the foyer of the hospital, and we found that there were a proportion of patients who we could redirect and send to the most appropriate place, which wasn't always actually into NSEC itself, but also to the urgent treatment centres or actually to their own GP. We did, however, notice that there were a group of patients who, if we had a bit more time with them, we could get an even better outcome for A, for the patient, but B, also for the receiving department, so they weren't seeing inappropriate patients. So that's how the model's evolved, and it's taken a lot of support and input from the emergency department. Jo's been heavily involved. We've had ambulatory care involved, so we've had the medical team there, and also the surgical team and the gynecology team. So primarily we've been focusing on adults at the moment, and we found that it's made a significant difference to the patient journey in that they've been getting to the right care quicker. And actually we've also been redirecting more patients away from the hospital, because their care doesn't need to be hospital-led.
Yeah, okay. So we know that it's really difficult for people to know if they're going to the right place. We've created a really complex healthcare system, haven't we, where people don't know whether they should be going to their GP, urgent treatment centre, or coming to the emergency department. So it sounds that the process we've put in now is just to help them get to the right place. So we've talked about destinations, and you've mentioned some of those. So people might not understand some of those things. Could you just tell us a little bit about it? So Jo, you can tell us a little bit what the emergency department does.
Yes. So one of the ways that we started looking at how to develop this was to ask each service about which group of patients would be best served in their own area. So we set some criteria. At the very front door, it's really just a conversation. So it's a hands-off conversation with a clinician to try and have some positive criteria for getting you to the right place. And as Julian said, that could be the emergency department, it could be ambulatory care, it could be UTC, it could be home at that point, but that's a hands-off assessment. We then have a group of patients that don't fulfil any of those positive criteria that go to a navigation process, and that's the extra step that we've put in to try and filter out the patients and get them to the right place. And that again is with a senior clinician who will sit down with somebody, have a consultation with them. There may be some bedside tests that are done, and at that point we would then move somebody to the right place and get them. The important bit about it was not to add an extra step that wasn't useful. So at each point we've done a lot of work in trying to get the IT and the documentation good enough that that information follows the patient all the way through the journey.
So it's really about understanding very early on what the need of the patient is and where the right place is for them to go. Prior to that, they would have just sat in the waiting room within the emergency department and then maybe found out they were in the wrong place down the line. Yeah, okay. So hopefully it's going to create a better patient journey at the end of it.
Yes, I think so. And the other bit that's important about it is the timeliness of it. So, you know, if you come to an emergency department, it's because you have something that needs immediate intervention, but there are patients that come into our system and to our services that don't need to be seen there and then, and actually would be better served if they were seen by the right person at a slightly later point, and this has allowed us to be able to do that safely. Yeah,
great. So you've both done both the streaming and navigation as part of your the involvement of this and just trying to learn what it's all about and help the process come in. So Julian, you've got an example of a patient that you've seen or managed or worked through the new front door process?
Yeah, from my perspective, I've got a background in the urgent treatment centres. So understanding that they see predominantly minor illness and minor injury, although I get that patients, where's that line drawn, and it's not always that easy to understand. So often we get people, and the commonest one that we redirect is, say, somebody who's injured their leg. They've tripped on the pavement, they've injured their ankle, they can't walk, so they come into the emergency department because they feel that's where they should be seen. Actually, an ankle injury, most of them can be seen at urgent treatment centres. So actually being able to assess their injury and understand that they don't need to see the emergency department clinicians means that then we can actually, as we've got an appointment system at our urgent treatment centres, we can book them into them, and we can also ensure that their x-rays are booked at the urgent treatment centre so they can have it as a one-stop shop, so they can get their x-rays first and then see the clinician. So it means that their journey, the patient's journey, although they have to go to another site, actually their total time in healthcare is much shorter, and they're seeing the right person for their needs. And as Jo said, it then frees up an emergency department clinician to see, you know, a really sick patient.
Yeah, okay. And Jo, how have you found? Have you got a patient that you can tell us about?
Yes, so I've done some shifts in the navigation part of the system, and I've had patients that have come through there, particularly later on in the evening, where before they would have sat in the emergency department waiting room for potentially quite a long time, to then see a clinician later on who says to them, you need to go somewhere else tomorrow to get the investigations and care that you need. And this has allowed us to be able to say, actually, you do need to see somebody, but you'd be best served coming back tomorrow to our ambulatory care department, for example. I'm going to book you an appointment. You're safe for now. Go home and come back tomorrow, and you can get your scans then and see the clinicians that will provide you with the best care.
And how did that feel to the patient? Were they okay with that?
Yes, so I think the patients that I've seen have all been very pleased with the services they've got. They've felt that they've been listened to, I think, that they've got an outcome, and have been pleased that they haven't been waiting a long time to then end up being sent away.
Yeah, sure. So if you were a patient walking into the front door of the Northumbria today, would you notice a difference as a patient?
Absolutely, yeah. In the foyer, we've got we're using the main reception desk there, and we've got information to say that you need to book in here, and then you'll be seen immediately by the clinician in the foyer in a cordoned off booth. So immediately patients will notice a difference.
Yeah.
And I think it's really important that we understand that actually not everybody needs to go into the hospital. So actually using the foyer as that first point is really important, because it helps people connect with the fact that they might still be sent elsewhere, but it'll be because that's the best place for them.
Yeah, okay. And have we had any patient feedback, sort of bigger picture patient feedback so far, or is that something we're looking to for the future?
I mean, we've had sort of informal feedback from patients. In fact, thinking about patient journeys, I also had a gentleman who lived not far from NSEC who had a head injury and had cut his scalp. We sent him down to the urgent treatment centre. On his way home, he actually came back in and said, actually, I was sceptical at first, but that was really great and by far the best outcome for me, and presumably for you as well. So that was really handy to know. We haven't got any formal feedback yet, and certainly that's needing to be planned, and we've got our patient services manager involved in that side of things to ensure that we do understand, because as with any change and new thing, there will be positives, but there'll also be negatives and things we can improve upon, and it's really important to pick that up from a patient perspective.
I think what we have been doing with the introduction of this is making sure that it's safe, though. So we have been following up to make sure that patients who have been directed away haven't then presented to our services again within the next 3 days or so.
And that's really important, isn't it, with any new process of clinical care, that you check what you're doing is right. And have you had any challenges so far with it?
Yes, lots along the way. There's the infrastructure, so the IT has been difficult, and there's been an awful lot of work done by some of our colleagues to make sure that the systems that we've got in place have allowed information sharing and have really made the process for the clinicians as easy, as simple as possible. And that's taken quite a lot of work, but there's been a lot of engagement there, so that bit's been tricky. There's been just the space, so getting a room with the right things in it has been difficult. And then I'm sure Julian agree, the biggest problem we've had is getting the right staff. So
Absolutely,
for both of the roles, for the streaming and the navigation, you need the right person doing it. And not everybody can do it, and it needs to be a specialist role in its own right, and that's been very difficult at times.
And presumably as you move forward, there'll be some training and some evolution of the staff that do it.
Absolutely. I mean, as with any new service, you learn about what the service needs, and you learn about what the clinicians need to know in order to develop a safe service. And we've certainly started on that pathway of starting to educate and observe the clinicians we've got, and then moving forwards, develop a training program so that for new clinicians who are interested and want to do this, we can ensure that they're as well prepared as possible for this role, because it is a challenging role and it is completely new for us and for our staff in the Trust.
Yeah, and my understanding is other people throughout the whole of the UK are looking at similar types of processes within their hospitals as well. Yeah, so Northumbria might be an example to be able to share. You talked about it's just adults at the moment, is that correct? Is there any plans going forward for children turning up?
Absolutely, yeah. I think we've realised that we couldn't do everything in one go, because it was just too big and too complex. So we've started on the adults, and we're satisfied that we've got a safe, robust process for streaming and navigating adults. We've started conversations with the Children's Emergency Department, because there are quite a significant number of children who turn up who could be benefited either from their own GP or from the urgent treatment centres. So there's beginnings of the work to get that up and running as soon as we can. And there's a separate arm that we've just had the very initial conversations about mental health, because a lot of mental health, because emergency departments, they're open 24 hours, they're often seen as that safe haven, yet they're busy places and they're not always the best place for people who are struggling with their mental health. So again, that's been one of my aspirations, and I'm pleased that we started on that, and it'll take time, but we will get there eventually.
Yeah. And just one other bit that is further down the line, but that we will need to look at, is that the same offer is given to the patients who arrive by ambulance that don't walk through the front door, so that we're offering the same opportunity and getting patients to the right place, regardless of how they arrive in the building. But we're not there yet.
Because that's not visible to lots of people, is it? That what's happening coming in the back door, and that's the people who are more sick and best benefited from the emergency department sometimes, but often there might be another better destination.
Yes, absolutely.
Yeah. So it sounds like there's lots of work going on, and I'm sure there's a process of just checking everything's happening and collecting data, which is always really challenging as well, isn't it? Is there anything that you want specifically to take out of the data, I guess, towards the strategy?
I think from a strategy, it'd be nice to know that actually the number of patients ending up in the emergency department itself is going down and reducing, because that means we're reducing the pressure on the emergency department. Also, along with that, it would be nice to be able to see that actually it is true that our belief is that a large proportion of patients who do turn up at NSEC actually are better off either managed in the community with their own GP or pharmacy or an urgent treatment centre. So we need to make sure that as time goes by, we're collecting that data so that we can see how we're doing and making sure we are delivering what we want this service to deliver.
Yeah, and presumably looking at themes of people who turn up at NSEC who maybe would have been better served elsewhere is important,
Absolutely.
isn't it? Because there's so much other stuff going on in the community and places where people can access, they just often don't know where it is.
I think that's right, and we sometimes forget, I think, that patients' time's important too. You know, and we kind of, the default is you sit in a busy emergency department for a very long time, and that's not good for anybody.
And I think most people listening to us will have identified or even been there with friends and family about how difficult that is. Great. So thank you. To summarise, I think this is all about getting people to the right place and the right people to manage their care first time, which is great. It's about helping people access and navigate our complex health system, but making some meaningful change within the trust with issues that people have identified historically as well, so take pressure off all of the destinations we've talked about and ensure that people that should be managed there are going there.
Absolutely.
Grand. So thank you very much for coming to talk to me today, and thank you to those people for listening to this podcast.